I'm Nathan Czerny. I hold the Normal Van Chair of Humanistic Medicine. I'm an oncologist and I'm the Chief of the Palliative Medicine Service at Czerny Medical Center. This is a lecture about the normative ethical considerations in the end-of-life care. Patients have a right to individual goal-focused care, and this right is no less true at the end of life. Well, who decides? There are several options. The patient can choose to make decisions alone. This is called often pure autonomy. More commonly, patients make decisions in dialogue with their significant others, such as family members or friends, and this is called relational autonomy. And occasionally, patients will decide to delegate decision-making to another person, say to a rabbi or to the treating physician or a family member, and this is called voluntary diminished autonomy. Goals of care can be summarized in three terms: either the optimization of comfort, the optimization of function, or the optimization of survival. And what's interesting and critical is that the relative priority of these goals can change over time. And what's important is that the decision-making must be relevant to the prioritization held by the patient. So, in some situations, patients will determine that the optimization of duration of survival is more important to them than considerations of comfort and function, and thus they may be prepared to undergo treatments that could either interfere with their function or cause them discomforts. In other situations, patients will say, look, it's just as important to me to prolong my life, but also to maintain my level of function and to maintain my quality of life, in which case we're trying to find a balance between the three. And in certain situations, particularly as patients progress towards the end of life, they'll commonly say that the most important thing to me is to optimize my comfort, irrespective of its impact on my level of function or how long I'm going to live. Goals of care set the context for decision-making, and treatments need to be appropriate to the prevailing goals of care. And this implies a right to self-determinate, the right to either decline therapies, to request a specific therapy, or a right to change the goals or to pre-negotiate planned goal re-evaluation as the patient's circumstance changes. Importantly, there is a profound difference between prolonging life and prolonging the process of dying. Under normative circumstances, the defaults for decision-making are to prolong life when possible, however, not to prolong the process of dying. Now, this is challenging because the distinction between prolonging life and prolonging the process of dying is not always clear. And there is a danger that the diagnosis of saying that this patient is currently dying can become a self-fulfilling prophecy, whereby a patient whose situation is very vulnerable, essentially the care team raises its hand and says, look, we're not going to even try to get them out of the situation any further, and the patient will just rapidly deteriorate to a situation where they are irreversibly dying. Now, some patients will say that they're not interested in life-prolonging treatments. Now, if the patient is dying, well, that's consistent with normative practice, and we would not normally challenge that. However, if the patient is very ill, but it's not yet clear that they're dying, this is a different situation. And beneficence demands, beneficence is the ethical imperative to do good for patients. Beneficence demands that this request should be explored to see, is it really authentic? Or is it possible that this is being triggered or driven by untreated depression, poorly controlled symptoms such as pain or shortness of breath or nausea or vomiting or other physical symptoms? Is it driven by an anticipation of symptoms or loss of control? Is it driven by a lack of perceived supports? And we even have some situations where patients will say, look, they're not interested in prolonging their lives because they're scared of becoming a burden to either their family or to the healthcare system. Irrespective, patients are entitled to a say about how they want to be treated in the event that they're not able to communicate towards the end of life. And this can be done through two mechanisms. One, through advanced medical directives, which would be activated in a situation of a life-limiting situation or deterioration close to death if the patient is no longer able to communicate. Or the other alternative is they can nominate a healthcare proxy. Now, the role of a healthcare proxy is not to make decisions in place of the patient, but rather this is the person to express the patient's opinions of what they would want should they not be able to communicate themselves. So these sorts of things that can be included in an advanced directive is to nominate specific interventions that the patient may or may not want. A patient may say that they would be interested in having nutritional support but not interested in having ventilation, or they'd be interested in having blood product support but not antibiotics if they were to develop a life-threatening sepsis. A patient can also say that they would like to have a trial of therapy with a planned discontinuation in the event that the intervention or the trial of therapy isn't effective. And they can also put in a pre-planned proxy override clause. So they can have an advanced directive so they wouldn't be ventilated, but with the right of the proxy to override this in the event of some unforeseen circumstances. So a well 50-year-old man may say that if I've had a massive stroke, I wouldn't want to be ventilated, but they've had a car accident now and they're coming unconscious and they're needing ventilatory support. In this proxy override allows the family to say that even though he has a DNR order, under these sort of circumstances, I have the right to override the advanced directive. Among patients with advanced illness, prolonging life, as I said, may or may not be a relevant goal of care. And if it is not a goal of care, patients have a right to request comfort care only. And this is the notion of allowing death to occur. And there is a substantial and important and morally important distinction between allowing death and killing patients. Patients have a right to choose not to have a treatment, to say that, you know, under certain circumstances I would want to withhold any attempts at either CPR or ventilation just to make me comfortable. Patients also have a right to have treatments that are not promoting their goals of care discontinued, withdrawing treatment. So, for example, a patient may say that if I'm in a life-threatening situation, I would want a trial of ventilatory support. But if we see that it's not working, I would want it discontinued and just to have to go to comfort care. This is called withdrawing therapies. And there is no ethical distinction is made between withholding, choosing not trying a treatment, or having a planned withdrawal if it's not effective. One of the common issues that comes up in end-of-life care is discussions about futility. When we're concerned, when patients request, for instance, cardiopulmonary resuscitation in a situation where you don't think it's going to be helpful, often physicians will say this is futile. Well, true futility is in fact rare. True futility is defined as an intervention simply cannot accomplish the intended physiologic goals such as the re-establishment or maintenance of cardiac function. So, for instance, if a patient has been shot in the heart and they have a massive ventricular rupture, doing CPR or putting the patient on a ventilator would be an absolutely futile situation. More common are what I call potentially inappropriate interventions. These are treatments that have some small chance of accomplishing the effect sought by the patient, but where the clinicians feel the competing ethical considerations may justify not providing them. This is actually the more common situation in discussions about CPR. It's not that it can't prolong the patient's life for even minutes or a small number of hours, but it's not going to prolong life beyond that. And in many situations, the treating clinicians feel that that's not an appropriate use of resources, an appropriate way to look after end-of-life care. So there is sometimes a tension between the commitment to individualized and culturally sensitive goal-focused care and between what the treating clinicians perceive as to what constitutes appropriate care. And this issue of appropriateness often arises around questions about artificial nutritional support, intensive approaches to life prolongation, sometimes the use of disease-modifying treatments in the setting of far advanced disease when the patient who's progressed after 3 or 4 lines of chemotherapy and immunotherapy asks for yet another treatment which the physician feels is just not going to be helpful. Sometimes in terms of requests for blood product supports, intravenous antibiotics, or, as I mentioned before, requests for cardiopulmonary resuscitation in the event of death. In this situation, I think the approach is firstly to explain and advocate for the treatment plan that you believe is appropriate. But it is really, really important not to conflate the terms inappropriateness and with futility. Because once you start bringing in futility in situations where it is not absolutely physiologically futile, this compromises your trustworthiness and integrity and compromises your place as an equal and trusted partner in the discussion. So to address this concern, the approach is to first listen and align concerns. We're both concerned with the well-being of the patient, so we're focusing on the interests rather than on individual positions. To explore the different options that may be available to consider, and to say that, that if we get even to try an option that we don't really support, but you feel very strongly about, to say, okay, we'll try it up until this sort of point, but have an agreement on objective criteria as to when it will be discontinued. Well, what do you do if in situations where the disagreement is an intractable disagreement? If the patient is being harmed, or if the request will cause harm to other patients, then this request should be declined. So an example would be with a patient with far advanced, immediately pre-terminal lung cancer with lungs full of metastases, and the family members are insisting that the patient wanted to be put in intensive care. Well, that would be at the expense of other patients who have a genuine chance of recovering and their access to that degree of care. And that raises the issue of harm to other patients. In this sort of situation, you can draw a line and say, look, that's just not going to be possible. In some situations, however, where there's an intractable dispute, it will ultimately end up in the courts, or there may be a need to appoint a new surrogate for decision making. The point being that surrogates should never be allowed to make decisions that are harmful to patients. So historically, up until now, in situations of the so-called futility, most of the effort has been focused on ways to override the request of family members. But as I said, this approach also undermines the respect of the rights of minorities and groups that have unpopular views. In some cases, the best solution is going to be to say, look, we will respect your views as long as it's not harmful to other people. As a team, we need to find ways to be able to tolerate these demands in a way which is not going to cause moral distress and moral fatigue to staff members, and finding better ways to support one another in those rare situations where we're called on to provide care that we in our heart of hearts aren't really comfortable with. So we recognize here that we have a conflict of duties. We have, on one hand, a duty to patient preferences, but we also have a duty to the well-being and preventing moral distress in our staff members, and also the duty to fair allocation of limited resources. And this ties in to the example that I brought before about requests for utilization of intensive care resources. There are some situations at the end of life where symptoms are so severe that the only way to provide adequate relief is to diminish the level of consciousness, and to diminish the level of perception. And this is called palliative sedation. This is an option of last resort at the end of life. The aim is to use the lowest amount of sedation adequate to provide adequate relief. This is proportionate sedation. The aim is not to kill the patient, but rather to make the patient comfortable. Now, there are clearly risks involved, risks of either overdose or risks of aspiration, but the benefit of relieving otherwise intolerable suffering justifies the risks. And this risk-benefit balance is the same sort of consideration that goes into almost all sorts of medical decision-making. I'm going to touch on the issue of elective death. Elective death refers to euthanasia and assisted suicide. Now, these are situations where either the patient asks to have someone end their life or to be given the means for them to end their lives themselves under medical supervision. Elective death is not the same as withdrawing therapy. These are active interventions to try to stop life immediately. Now, these remain controversial subjects. However, it's important to be aware that this approach has been legalized with regulation in some countries and states, and indeed it is becoming more common in different parts of the world. What are the arguments for and against? Arguing for it, one can say that this is an issue of respect for persons and for self-determination, that the availability of elective death enhances patients' sense of personal control, and it gives them the chance to avoid the risk of suffering. On the other hand, some would argue that either participation in either the killing of patients or giving patients the means to end their own lives is outside the purview of normative medical care. There are concerns of the potential for abuse, and indeed, in case studies in the Netherlands, it is very clear that there have been many cases of abuse. And finally, some people would argue that choice creates a coercive pressure on patients, that by giving the patient a choice to say, well, it may be reasonable to end their own lives, that there is a subtle pressure to say that maybe you and your family would be better off if you were dead. So what I've tried to illustrate here and to describe are what I call normative secular ethics. And there is an intrinsic tension between normal secular ethics and religious law, political interests, particularly in the construct of coalition government in Israel where we live, and sometimes with idiosyncratic cultural issues. And this is why there are idiosyncrasies to end-of-life care in Israel, and there's a substantial gap between normative ethics and the end-of-life laws in Israel. I hope that this lecture has given you some background on the important considerations here, particularly focusing on issues of goal setting, making sure treatment decisions are appropriate to the goals of care, recognizing the distinction between prolonging life and prolonging the process of death. And I hope that this understanding will help you in your future deliberations through this course. Thank you very much for your attention.